So there's been substantial expansion of options with axial spondyloarthritis and PSA, including multiple IL inhibitors, IL-23 pathway agents, and JAK inhibitors, as you've mentioned. What are the key differentiating features that matter most for a busy clinician when choosing a mechanism of action?
Right. So I would say it really just depends on the patient's comorbidities. For example, even within classes of drugs, for whatever reason, someone might be on etanercept, which is a tumor necrosis factor inhibitor. But if they have, spondylarthritis with associated eye disease, uveitis, etanercept doesn't work that great for the eyes. So it wouldn't be like a good option for that. So it really just depends on the patient's comorbidities, and that would determine which drug you would choose for the patient.
How often should clinicians realistically be assessing disease activity and adjusting therapy in axial spondyloarthritis to align with treat principles without maybe overwhelming clinic capacity?
All right, so it really depends on the stage of the patient's diagnosis. Earlier on, when things are really active, you really want to see them a bit more frequently, like, every 6 to 8 weeks, to sort of, give medicine some time to kick in before you determine whether or not you'd want to, switch. I mentioned earlier that you really want to give the NSAIDs about 4 weeks to determine, what's appropriate. The biologic agents seems to act a little bit longer, so maybe 10 to 12 weeks before you really determine, that the full effect should have been in by now. And at that point, you might want to decide whether or not you want to increase dosing or change therapies. So I would say, 3 months, 12 weeks thereabout.
Mhm. So let's talk a little bit about non-pharmacologic care. So physical therapy and exercise are emphasized as foundational in treatment recommendations. How does high quality exercise intervention, what does that look like? And what does that look like beyond telling patients to stay active?
Right. So, thanks for bringing that up. That's such an important, point, and I think something that's so important to me, not just pharmacotherapy, but just holistic therapy. So, one thing I'll say first is that intervention as exercise, sorry, outside of quality of life for the joints itself. Like, it's something that's so important, just mental wise for patients, right? So, especially women, sometimes they have a more delayed onset of diagnosis, because their disease tends to be probably a lot of times associated with what some people might call fibromyalgia, or they have a lot of depression associated comorbidly with this. So exercise is pretty helpful in this regard. I think seeing a physical therapist is also very helpful. A lot of times patients with their chronic back pain, sometimes they might, adjust their gait or change the way that they might, their posturing and that sort of thing. And that might cause uneven, loading and weight bearing on other joints. So it's not uncommon that persons might actually, their initial complaint might even be like hip pain, because they're starting to develop hip osteoarthritis just from, just changing their gait a bit. So seeing a physical therapist and having like structured exercise is something that's great. Low impact exercise such as swimming or cycling, all of those are pretty helpful. But I would also say that, if you're not able to see a physical therapist or have something that is structured, like, some exercise is better than no exercise at all, whether it's like gentle walking, walking up a hill. Swimming, as I mentioned, is a really great one.